Good afternoon, everyone. This is Andy Reese with Department on Disability Services. Welcome to our weekly forum, but just as a reminder and some notice a little bit in advance, it won't be weekly in the month of November. Next week, Thursday, hold on 1 minute because we don't seem to have an ASL interpreter. So I'm going to pause for a moment while we resolve that, and then I'll get started. Looks like we are good. Perfect. Okay, so next week, as we had announced last week, there will be no forum the day after Veterans Day. And similarly, 2 weeks after that, the day after Thanksgiving, we will not have a forum. As always, I will start by sharing our data, although I can happily report that our data this week is very similar to our data last week. One of the few updates, I believe, will be related to the vaccine data. So we are now in November. We have had no COVID cases so far in November. During the month of October, we had 2 reported COVID cases among the people we support, and both of those were breakthroughs with people who had been vaccinated. So as we reported last week, the COVID cases break down by placement type. In host home, there have been 9. In intermediate care facilities, 114. In a mental health facility, there was 1 person. In the natural home, 62. In a nursing home, 2. In out-of-state placements, 4. In residential habilitation, 41. And in supported living, 213. And it is important to keep those numbers in context. That's why I provided also the overall number of people who are in the various placement types, so that you can see that while that supported living number may look big, it's not as big as the it's actually getting closer now to the percentage. The one where we're in best shape is regarding natural home, which has been 14% of our cases, but represents 39% of the people we support. So the 114 people in ICFs represent about 38% of people in ICFs who have contracted COVID. Amongst those, we have had 28 people who subsequently died, but only 13 of those deaths have been confirmed as COVID deaths. So that represents about 11.5% of people in ICFs who contracted COVID and have had a confirmed COVID death. In natural homes, 6.8% of people in natural homes have contracted COVID. There have been 6 people who have died. 5 of those are confirmed as COVID deaths, representing just a little over 8% of people in natural homes who contracted COVID and went on to have a confirmed COVID death. In residential habilitation, it is also about 38% of people. 41 people is about 38% of people in residential habilitation placements. 3 of those people have died, but only 2 are confirmed as COVID-related deaths, representing just under 5% of people in residential habilitation who contracted COVID and then went on to die from COVID. In supported living, the 213 people represent about 22% of people in supported living. Of those, there have been 25 deaths, but only 15 are confirmed COVID deaths. So of the people who contracted COVID in supported living, about 7% of those people did die from COVID, confirmed COVID death. Overall, the 446 people supported by DDA who've contracted COVID, which I've reported before, includes 2 people who have been reported twice with 2 COVID infections. We have had 65 deaths, but only 37 of those are confirmed as COVID. So of the people supported by DDA who've contracted COVID, about a little over 8% of those people have had confirmed COVID deaths. In terms of placement type, in the month of October, it was 1 person in supported living and 1 person in a natural home. And as I said, it's November 5th, and to date, we've had no reports of people contracting COVID. People who have contracted COVID who've required inpatient care for that, we have not had anyone who's required inpatient care since April of 2021. And as I indicated, people who have contracted COVID and subsequently died, the last death we had, there were 2 in October. Keeping in mind that of the 65 people, 16 are confirmed as not COVID related, and for 12, we are still awaiting the confirmation of the cause of death from the Office of the Chief Medical Examiner. And so the total confirmed COVID deaths are 37, and the most recent confirmed COVID death was in March of this year. Among staff, we added, I believe, just 1 this week. The total staff who reported a positive COVID result is 741. 52 of these have been reported by more than 1 provider, and we have had 10 provider staff who have died from COVID. And the vaccination data, so for the people we support, it's at 80%. In host homes, that's 86%. For all of these, I rounded up except ICF, because if I rounded up, it would say 100%, and we still have 1 more person in ICFs so that we would reach 100%. So it's at 99.6% of the people in ICFs have been vaccinated. 65% of people in natural homes, 98% of people in residential habilitation, and 90% of people in supported living. We get updates every 2 weeks from provider staff. So as I reported last week, 90% of provider staff have been reported as fully vaccinated, and 94% of DDS staff are fully vaccinated. So this morning we have a guest. We received some questions this morning, and I will answer those questions a little bit later on. We have a guest this morning from DC Health who is going to provide some information about a project that DC Health, along with the CDC, if I'm not mistaken, has been working on to provide education on infection control for facilities. So Maribel Sabio can tell you more about that. And she, I believe, should be able to share her screen at this time so that she can share the documents with you. And she has shared with me a copy of her presentation, which we will be posting on our website after today's meeting. So Maribel, welcome, and please go ahead.
Good afternoon, everyone. Can you see my screen?
Yes.
I just want to make sure that, okay. Good afternoon. My name is Maribel Sabio. Today I am presenting about CDC's project called Project First Line. In this presentation, I'm going to discuss what Project First Line is, who Project First Line is for, the training modules available from Project First Line, and why you should use Project First Line. Project First Line is CDC's national training collaboration with diverse healthcare professionals and public health experts that can provide up-to-date infection prevention training and education for frontline staff free of charge. DC Health can assist facilities in selecting the appropriate training modules based on their facility needs. You can mix and match the training modules and choose the length of the training session according to your needs. We want healthcare facilities and all frontline healthcare workers in the District of Columbia to take advantage of this free resource. Project First Line has been created and vetted by healthcare professionals and public health experts for frontline healthcare workers and also frontline healthcare support workers to provide engaging and innovative infection control and prevention training. The training modules and contents are designed so that any healthcare worker, regardless of their educational background and experience level, can understand the content, and this will help them effectively and confidently apply it at work, home, and everywhere else. Project First Line can be a great asset for your facility's infection control program because the training modules can be applied to a variety of situations that can ensure all your staff become experts in infection control. Your facility can incorporate it as part of a new hire orientation or intervention for a plan of correction, annual in-service for staff, or just a brief 10-minute refresher before or after your huddles. Some training modules available through Project First Line can also provide continuing education credits, such as CNE for nurses, CPE for pharmacists, and CMEs for medical providers. More importantly, the training modules can be mix and match according to your facility's needs, but also you can choose the length of the training. So for example, you can choose the 60-minute training session for new hires or annual in-service, or you can do the 20-minute session for a lunch and learn session, or the 10-minute for micro-learning sessions. Currently, there are 14 training modules available in English, and 5 of those have already been translated into Spanish. Also, when facilities join Project First Line, the moment that we have a new training module available, you will be notified of that, and also you will get a copy of it. Inside each training modules are short videos to keep the staff engaged, as well as breakout session and questions to help facilitate learning and meet the objectives of the training session. The videos for Project First Line that are embedded with all our training modules, some of them are 2 minutes, and the longest one is just a little bit over 9 minutes. The average video is less than 5 minutes long. We want Project First Line to be part of your IPC program and ensure its sustainability by offering train-the-trainer sessions so your facility can have their very own Project First Line facilitator. This will empower your facility and your frontline staff to have the knowledge, resources, and confidence that they have the most recent infection control information at their fingertips. It's a life skill that everyone should have. Project First Line is practical and teaches a life skill that everyone can count on and can be tailored by each facility according to their needs. By training your staff to become a Project First Line facilitator, we can be rest assured that the program will be sustainable and continue to provide critical information that will help your IPC program remain successful. Learning infection control at the comfort of your home or during your lunch break makes Project First Line easy for everyone. If you're interested and would like to get more information on how Project First Line can be incorporated and tailored to your facilities, infection control, education, and training, we would love to talk to you. I will also drop in the chat my email for everyone to have, just in case you have any questions for me. Thank you so much.
It's helpful that I can see Matthew because when he's not saying anything, I realize that I am still muted. So Maribel has put her email address in the chat, and once again, but this time so she can hear, thank you very much for your presentation. I hope that our providers will take advantage of this resource. As I indicated before, we did receive a few questions this morning, so I will walk through those first. And as always, if people have questions, please type them in the chat and make sure that you address your question to everyone. So first, what is the notification process for providers as it relates to an exemption decision? If people recall, when DC Health presented on this, the response was that it is the person who enters the exemption request and the person who receives the response from DC Health. DC Health does not notify their employer. So maribel.sabio@dc.gov. People, I'm seeing from a lot of people that they don't see this in the chat, but I'm looking at Maribel's email right above all the others. So any questions related to Project First Line would go to maribel.sabio@dc.gov. And what is the time frame for an exemption decision to be made? My recollection was that it was expect 45 to 60 days. You know, as they indicated at the time, rolling this out, they didn't know how many exemption requests they would have to be considering. So it was hard to give a clear, a specific response to that. But they expected to have responses within 45 to 60 days. So if your staff has provided evidence that they submitted something via the portal, within 2 months, you should be able to ask them, can you show me what response you got? If the exemption decision is not approved, is termination of the staff the only recourse? It seems to be that at the point, if a staff person requests an exemption, from the date they request the exemption, they can continue working. As a provider, you can require regular testing of them. As soon as they receive that response, if they do not have either a medical or a religious exemption, they are required to be vaccinated. So if they've requested the exemption and it's been denied, the only other option is for them to get fully vaccinated. And if they are not able to do that, then yes, they could no longer continue in employment in this area. And I know that within the district government, while for many people there is this option of testing, if they are opposed to the vaccination. For a large group of people, there is not that option. And so we are dealing with that same issue ourselves, reaching out to staff who have a mandate to get vaccinated and making sure that they comply with that so that they can continue providing the support they do. Can you please explain how the Appendix K can be used for relaxing the staffing ratio as recruitment efforts continue to fill staff openings? So, Winslow, I might need you to back me up some, but my recollection is that, first of all, for any staffing, you need to make sure that there's an emergency backup plan in place. The Appendix K allowed that if that backup plan was not adequate to fulfill the staffing ratio, that the staffing ratio could be relaxed while ensuring that the person's health and safety needs were met and that documentation should be maintained. We recognize that I think that there's some need for some more clarification on how that process works. So in the next couple weeks, we will be sending out a transmittal that fully explains all the issues related to this question regarding staffing ratios. So if I've missed anything, Winslow, please jump in and clarify.
You did an excellent job, Director Reese. You covered it all. Thanks.
Thank you. Please clarify over-resource issues as it relates to stimulus payments. MCIS issues are being generated, though it was presented during a recent leadership meeting that stimulus payments will not count towards SSI benefits for eligibility. So first of all, that second statement is true. SSI eligibility as it relates to income and resources will not count stimulus payments. However, Medicaid does still have a resource limitation, and that has not changed. What has changed is during the course of the public health emergency, Medicaid won't be terminated for anyone. However, we're not waiting until currently the federal public health emergency has been extended into January. And so Medicaid would continue until the end of the month of the public health emergency. We're not waiting until January to make sure that everything is being done to maintain a person's Medicaid. And so as recertifications would be due, were it not for the restriction on terminating, as those would be due, they are going through and making sure that everything is in place so that they can be done, so that people maintain that eligibility without a gap once the public health emergency ends. So while it is true that the stimulus payment doesn't affect your eligibility for SSI, it does affect your resource limitation for Medicaid. And we are trying to make sure that we're following all of the necessary steps so that nobody has any gaps in their Medicaid eligibility at the end of the public health emergency. Do we know how many exemption requests were received? No, we do not. Yesterday, several staff reached out about the deadline for the vaccination, that the deadline was moved to January 4th. Is this a fact? You know, this is what's a little confusing, perhaps, about all of the different vaccine mandates that we've had. January 4th is a federal deadline for certain health professionals paid through Medicaid to be fully vaccinated. The district has its deadline that we disseminated, which required that everyone receive their first dose by September 30th, which means that by this date, everyone would have had to have received their second dose. So all staff, there was a date certain in October that all staff would have had to be fully vaccinated, according to the district mayor's orders and DC regulations that were put in place. So it is true that this broader federal mandate came down this week. There were two, actually, one that came from the Centers for Medicare and Medicaid Services, and one that came from OSHA, Office of Safety. Is it Office of Safety and Health? No, it's Safety and Health, but at any rate, it's OSHA.
Occupational.
Occupational, thank you. Safety and Health Administration. So OSHA has a requirement for all employers of more than 100 people. And this was posted this week. And that was a vaccine mandate. So it included a testing option. The CMS did not include a testing option. However, both of these are later dates than the requirements that have already been imposed by the District of Columbia. And that federal requirement did not change anything about the district requirement. Certain retainer claims are being denied for a number of providers because of a common issue. My team contacted DHCF via the billing TA form in MCIS, was told that the system looks for a paid or to be paid claim within the last 30 days of the service dates being submitted. If there is none, the system will deny the retainer billing submission. However, with respect to the retainer payment, a lapse of 30 days or more should be expected. This is a really long question. I believe, okay, so who can we contact to resolve this? It's holding up a lot of the retainer billing. I always close my email before I start this because when I'm sharing the screen, I don't want to accidentally share email, but we did get an update on this. And my understanding was that DHCF was, hold on one second and I will tell you, that these were being resubmitted this week, I thought, but hold on and I'll make sure I'm not misquoting what was said about this. All denied claims will be reprocessed. This was resolved this week. So there are 17 providers whose retainer payments were affected by this, and DHCF has said that these claims will be included in this week's payment cycle and included in next Friday's payment. So they have addressed that problem and it should be resolved. Does the provider wait until DC government responds to the attestation form before moving forward with staffing? I don't really understand that question. So if any of my staff understand the question, please feel free to jump in and answer. Otherwise, if the person asking it could give me a little more to work with there, because I don't understand the question.
It seems as though they're asking whether they have to take the staff off of maybe the staffing ratio or either the assignment before they get the attestation form. That's what I kind of read from it.
What attestation form?
That the person has a religious exemption or a medical exemption. That's what I'm reading from it. But certainly to Ms. Curry, if you could clarify.
She just said correct. So I guess did you answer her question? I mean, so it's a waiver request. And what we were told when DC Health was on the call is if a person submits a waiver request, that until there's a response to the waiver request, the person can continue working. What if the staff for a person is the parent or relative and does not comply with the COVID rules and regulations that DDS has put in place? Will the person keep receiving services through another DSP? If yes, some parents don't want people in their homes, so will the person lose their services? The provider cannot bill during this period due to lack of documentation of either an exemption or a vaccine. What should we do? This is for natural homes particularly. It seems to me that you answered your question in your question. It is true, if a relative is paid as a DSP, they are a DSP. And therefore have to comply with the requirements for DSPs. If they don't want to comply, they cannot be the person's DSP, even though they can continue living with the person. So, their contact with the person may be the same, but in the district, we're not to use our home and community-based service waiver funds to pay for people who are not vaccinated to provide services for folks. If they don't want other people in their home, then they should be talking with the service coordinator about how to get supports for the person. And you are correct that the provider can't bill if the person is not complying with these rules. So while the exemption requests are pending, can providers require weekly testing? Yes. Providers can require weekly testing. The regulation didn't require weekly testing, but indicated that providers could. Regarding the retainer payments, just to be clear, providers don't need to resubmit denied claims, correct? That is correct. DHCF is processing those. I mean, his email seemed to say they were doing it today, so that's correct. What is the status regarding the booster doses of Moderna for the people we support? Perhaps DC Health could weigh in. I thought Moderna, my understanding is Moderna is approved and is available. I know when I went to get a booster, one of their questions was, had I taken Pfizer or Moderna? So I assumed that meant Moderna was available.
That's correct, Director Reese. Moderna is available for administration 6 months after completion of a primary series.
And these seem to be, I mean, this is totally anecdotally from everyone I've heard who has gotten a booster. We do not have any of the supply issues that we had when the vaccine first came out. Last retainer question from you. Sorry. So I doesn't bind others. There is more billing to do. Has the retainer issue been fixed in the billing system, or should we wait to process the rest of the billing? So I saw the draft this morning of the rates and the transmittal that will be going out. So you'll get a transmittal that will clarify the July 1 moving forward rates. And I would ask that you not submit those until you get that transmittal, which should be coming to you shortly. And so just as a reminder, on the CDC website, you can find the guidance regarding the boosters, and people should be talking to their healthcare provider about how those recommendations on the CDC's website apply to them. So I see the question. I don't know if this was here before I just said that. Is DDS encouraging providers to have discussions with people they support about getting the booster? Yes. Correct. The CDC guidance, Robin Shafford is sharing, includes recommendations for boosters based on both living in long-term care as well as underlying medical conditions and age. She didn't say that, I added that. So if you look at the CDC recommendations, and it's also based on the vaccine that you received, because their recommendation regarding Johnson & Johnson seems to me to be broader than the others. Not making a recommendation here, reading from their site. As I said, people should talk to their own healthcare provider, but the CDC website says people 18 and older who received a J&J vaccine at least 2 months ago should get a booster. The J&J vaccine has lower vaccine effectiveness over time compared to mRNA COVID-19 vaccines, Pfizer and Moderna. But as I said, people should make sure, consult the CDC website, consult your doctor, and get advice for yourself. Because for the Pfizer and Moderna vaccines, there are a number of different options based on your living situation, your age, and your any underlying medical conditions you may have. If a person is not vaccinated based on their decision not to be vaccinated, does the provider need to provide any documentation that the person is exempt? Because PCR always surprises us. So I met a few weeks ago with our PCR folks, and they have a weekly meeting where they review updated policies and regulations to make sure that they are monitoring compliance with current policies and regulations. There is not a mandate that the people that we support get a vaccine. There's a recommendation that they should get a vaccine in some circumstances. And a recommendation that you should is not a requirement that you must. The people we support have the same rights to receive or reject healthcare treatment as the rest of us, depending on, there could be some circumstances where there is a healthcare decision maker in place who either helps that person or makes those decisions. But the people we support are just like the rest of us. So we provide them with education. But no, if a person is saying that they don't want it, now I will say we track the people, and every single person we support should have in the COVID tab documentation that either the person has been vaccinated, a scanned copy of the card, and yeah, that would be it. The dates that they got the vaccination, which is on the card, or if they've not been vaccinated, the form that indicates why they've not been vaccinated and what ongoing education, which should be updated regularly, is being done with them regarding the vaccine. So that's what needs to be in MCIS. We look at that. I don't think that is I don't believe, you can correct me when, so I don't think that's in a requirement that PCR or Kirk, I don't think that is something necessarily that PCR is going to be looking at. They will be checking staff vaccinations because the staff vaccination requirement is part of the qualification of the staff to provide the work that they do.
That's correct.
Do people have to take a weekly COVID test? No. No, they do not. And DC Health has guidance about COVID testing for people. You should consult the coronavirus.dc.gov website regarding that issue. When will we know who will have the new PCR contract? What is the status? I don't know that we have an update on that status right now. Jared may be here and can provide an update, but I'm not sure that we do have an update. Yeah, if Jared's here, perhaps he could provide whatever update, but like I say, I'm not sure.
Yep. Andy, I am here. And you're correct. There is no status to update the group with currently. So as it stands, we're still operating as we have been. As soon as we have different information, we will certainly supply it.
And we have no reason to believe that there will be any lapse in the provision of PCR services. So, we have an agreement in place currently that's temporary. There was a solicitation some months ago, and PCR will continue to be provided, and we'll provide updates about which entity is providing that as we have them. Is that? So once again, I received a letter from DC Health that I was in violation because they had no record of me being vaccinated as a healthcare worker. I replied accordingly with my record of vaccination, as I did to the provider and then to DC Health. Is this something that has occurred to others, to your knowledge? Not to my knowledge. And if there are people here that are aware, one agency is saying they had 2 staff who received similar letters. My hope is that by responding in this way and providing the documentation, that would have been resolved. It says we reached out to our QRS per the direction in the letter. It seems to have been an issue with TME license numbers. I don't know, Kirk or Winslow, if you can address that. To me, that's confusing because DC Health suggesting that you reach out to your QRS just seems unusual to me.
Yeah, that doesn't sound like something that I've ever seen. And could the person, Miss Eva Chisholm, can you say what letter you're referring to? Are you specifically referring to a letter from DC Health?
My hope, if you reached out to your QRS, is that you provided them a copy of that letter, and then we can understand better what's occurring there. Because issues with TME license numbers, it seems to me, are issues with DC Health. And we have previously provided the contact information for the person at DC Health who is assisting with these TME renewals. Yeah, it says that she also reached out to DC Health. She was surprised that they directed her back to DDS. Yes, as are we. But as I say, I hope that you provided the QRS with the letter so they can pass it up the chain and we can try and help you to resolve this if you have not already been able to resolve it with DC Health. Do you have any updates on revised, updated DDS policies? Is there a specific policy that you're asking about? So when a policy is finalized, typically it's signed off on by me and then it is published. So if you haven't seen those, then they are still being drafted. We did reinstitute our HCBS policy group meeting to get input from people. And whatever policies are discussed there, I would just recommend those meetings are available virtually, attending that meeting and ask about whatever specific policy. So it's about 2 minutes of one. We'll keep it open till 1 o'clock. If some of the service coordinators / nurses don't understand that medical appointment take a longer time to schedule, and we get provider issues even though we respond to the dates of the appointment, which are pushed back. This affects the report card and the QRS, or assigned nurses don't care. It's going to be hard for me to, I'm trying to respond in a really measured way. Because if, we have been in this pandemic and public health emergency since March of 2020. People with chronic health conditions, we've heard a lot recently about real concern about people not following up with routine health screenings. It is essential that people follow up with routine health care. And what that requires sometimes is better planning. If someone requires an appointment every 3 months with the doctor because of a health condition they have, then it's important that that person contact the doctor's office with enough anticipation to have that appointment scheduled timely. For a very long period of time, remote was available, and that was a question, as we said, over a number of months that should be addressed by the healthcare provider. They are the one that can indicate whether a particular health service can effectively be provided remotely, or if they feel they need to see the person in person. So, I'm trying to walk carefully here to not sound like the assigned nurses, because the reality is, we have people who are responsible for ensuring that the medical care of some folks with complex health issues that need routine medical care. All of us need to take care of our routine health, including not only medical care, but routine health about nutrition and exercise and all of these things. So is that more complicated than it was previously? Yes, and it may even require more planning, but it is still essential. I was told that that people in ICF can't return to our day hab because they can't remove masks on their own. Is this accurate? So anyone who's going to go back to a day service should be doing the CPAC. I think most everyone has done them. First of all, to be clear, if a person can't remove a mask on their own, they shouldn't have a mask on. If a person is in a building with other people, then they need to have a mask on. So there is a certain logic there that there are some people who are not going to be able to go to a congregate day setting if they're unable to wear a mask. But as I said, those are going to be questions that need to be answered for each individual person. But yeah, that is a very real possibility that a person who is unable to wear a mask should not be in a day setting where they're going to be sitting near other people unmasked. Because currently, while we are indoors, I could turn my camera around so you can see I am in a closed office by myself. But anytime I leave my office, I have a mask on. And so if a person is not able to wear a mask, there really needs to be a conversation about the safety of that person being able to participate in particular activities. Doesn't mean they can't do anything. It means there needs to be a conversation about what they can do. And there should be real consideration given then to perhaps doing some kind of remote support for the person, doing some kind of individual support that could happen in their neighborhood, figuring those things out. These are complicated times still. And the IDT, the interdisciplinary team, should address this together to talk about what's best for the person. Because I have to tell you, just staying home for, I don't know, 6 weeks perhaps, was a lot for me. So I cannot imagine for some of the folks we support having to not being able to go out. So it's essential that we're taking care of people's physical, as was just brought up, and mental health. Regarding medical appointments, I'm sure you're aware if you try to call too early before an appointment is due, you're not allowed to schedule the appointment. When you call in a timely manner, the available dates are way out, which ends up meaning you don't have a current appointment complete. Why should the provider should be blamed for this if we have documentation supporting our efforts? Because you're responsible for ensuring their health care.
And the other thing I would add to that comment is, over time, what I've seen is that, let's say you get an appointment that's scheduled out longer than is recommended. I've seen where those appointments get missed and then it's pushed out even further. So while the provider may not agree with the manner with which we attempt to remediate this issue, it is necessary that we track these things, because I've seen people who've been doing appointments, say within 60 days, and when that date comes, something occurred and then it gets pushed out another 60 days. And then in fact, you have a person who's missing a critical health need 120 days out. So if anyone would like to discuss that type of issue further and bring some remedy on how we can come to a consensus, we can't just ignore this issue.
And I see that it's 1:05. I also see that if there are issues with MTM transportation, please contact Desiree, DESIREE .williams3@dc.gov. So have a good 2 weeks, everyone. And we will talk again on November the 19th. Thank you very much.